with so many people, and we are also able to, it was supposed to be one class, now we are able to schedule it as two classes. So just to recapitulate, I think most people would have attended, but some are already writing about missed last classes. I think I'll take 5 minutes to summarize what we did, and then I think I'll share this slide with Sudhakar, who can send it to everyone. So what I wanted to say is murmur is something which you have to befriend. It is something which looks very exotic in the beginning, but as you keep seeing more and more, you realize that it is easy. It's not that difficult. Explanation is one aspect of murmur, where you tend to explain it as using series different words, but then you realize that when you actually hear it, it could be different from what you imagine. So as we were discussing, it's like your friend's motorcycle, that when you hear that vroom sound, it is that particular person's, but when somebody asks pitch and point, it becomes difficult. The second point which we discussed is timing, which is very important, that systolic, diastolic. Do not try to time it with S1, S2, because you are very likely to go wrong. Time it with systole, diastole. What is systole? Either apex moving up or carotid. So you should only be telling with carotid, without carotid, or with apex, without apex. Anything with is actually systolic, and whenever you are confused, it is most likely diastolic. That's the first aspect. Second was, identifying, although there are many pansystolic murmurs, the timing was very important. Although there are many pansystolic murmur, MR as well as VSD, both defined almost the same way, are not the same murmur. One step, MR is very pure, very it's like almost one sound going throughout, whereas in VSD, you could feel the eddy current. High pitch murmurs do not have thrill, and they're usually, they are very pure and they do not have thrill. MR does not have thrill. Even when there is thrill, it is most likely to be diastolic because of the flow. VSD, AS, these are actually technically medium pitch murmurs. So do not go by high pitch with intensity. Intensity of murmur is different from pitch. Lower the pitch, more rustling it becomes and more palpable it becomes, like MS murmur. Like, VSD also is because of the medium pitch aspect, you get it. So that's how you classify. Then we discussed how to distinguish, say, MRTR, how to distinguish certain kind of murmur. We did discuss all of them. So with all that, I think one more very important point, which I would like to re-emphasize, is that how to use the bell and how to use the diaphragm. Whenever you press either of them very hard, they become diaphragm. That means you only get high pitch, low pitch disappears. Whereas when you keep the steps very slow, it could be either. You could have kept a bell slow, or you could have kept a diaphragm very, just as if it is touching. Then you are likely to, you are going to get both high pitch and low pitch sound. So the difference between these two, do not do intermediate auscultation. Like you're in apical area, either you press it hard or keep it light. When you press it hard to keep it light, the difference is the one which gives you variety of information. When you keep it light, you hear S3, you hear MDM, which is very rustling. And then when you press it hard, these both disappear. That's how you're very sure that was S3 and not, a click or sound. And that was, that was MR. That's how you know. Now, today's class, I think we should concentrate on diastolic murmurs, because that was the point. We did a lot of discussion on systolic murmur in the last class. So in diastolic murmur, again, there could be left-sided event, right-sided. There could be mid-diastolic, or hollow diastolic. There could be early diastolic. There could be a mid-diastolic, and some are called pre-systolic or late diastolic. We typically call them pre-systolic. So depending on the time, depending on where it is, we can identify this, and we can also identify right to left difference. Now, what are early diastolic murmur? Murmur which starts exactly with the second R sound. Now, if it is AR, it would start with A2. And if it is PR, it would start with P2. Now, these are the whole difference. So here, when we are talking about the idiom, there are two, three things we should know. Is it AR or is it PR? Because their site of murmur is very close to each other. And among AR, PR, in PR, you should also know whether it's a high pitch PR or whether it's a normotensive PR or a typically a low pitch PR. Now, what is the characteristic of AR murmur? The murmur itself is very characteristic, but the one thing about this murmur, most younger people tend to miss it. Your examiner will never miss a AR murmur. So very carefully auscultate for that and use all the maneuvers. Make the patient sit forward, keep the stats and make them lean forward. That's when you get a murmur. This murmur is typically like, something suddenly falling, you get that. It's a high pitch murmur, hence it's pure. The quality doesn't change. It's not as loud as you want it to be. It may not be that loud. And suddenly, it's like as if somebody is falling down. You literally get that feeling when you're auscultating for this murmur. Now, what are the important thing? The length of murmur, it's high pitch all the time. Very rarely, when it is extremely severe, it could become moderate pitch. That's where it could be slightly palpable. Otherwise, it is probably the only diastolic murmur which is high pitch. As we discussed, since there is a lot of pressure gradient between aorta and LV in early diastole, so it's typically high pitch. Pitch is typically pitch and intensity. These two, they have relation to gradient across the valve. Now, if it is a severe AR, what are the things? In all lesions, you should question yourself. What are the what is the finding in which I am going to say that this lesion exists, and what is the point when I'm going to say this lesion is severe? This is very important. I want you all to discuss among each other, understand. Like when will I diagnose MS? When will I not diagnose MS? And if there is MS, when will I say it is mild, moderate, or severe? Or how will I say mild, moderate, and severe? That is all that is needed in cardiology. For example, in AR, the idiom or early diastolic murmur is a must to diagnose. It has to be high pitch, hence it is best in the diaphragm, and it is best in the left third intercostal space. Now, when you hear it, what do you get? You get a murmur which is decrescendo, because in the beginning, the gradient between LV and aorta is more. It is decrescendo. It goes on decreasing as it is seen in the diagram. So you have a chronic AR and you have an acute AR. Chronic AR, let's talk about chronic AR now. In chronic AR, the murmur, the severity depends on the duration of the murmur, not intensity, but duration. So longer the murmur, more severe the murmur. So you diagnose severe AR when there are peripheral signs, when you have Austin Flint murmur, and when your diastolic BP is extremely low, and when the murmur is very long. That's when you diagnose a severe AR. Now, acute AR, on the other hand, the murmur could be a little shorter, and you could have S3 in acute AR. You rarely have S3 in acute chronic AR. You rarely have S3. You could have S4, but S3 is unusual. So that's how MR and AR differences. In MR, S3 is very, very common, whereas in AR, chronic AR, S3 is unusual. Whereas in acute MR, S4 is common because the atrial boost will be involved. In chronic AR, S4 is unusual. Why in acute AR, S4 is unusual? Reason being, acute AR, because of the maybe a valve rupture, maybe infective endocarditis, maybe post ballooning, post TAVI, the LV now gets suddenly full, and there is a premature closure of the mitral valve. So whenever you have premature mitral valve closure, you don't get a A. Hence, you don't get a S4. It closes way early. So we need to know about chronic AR and acute AR. I hope all of you followed. Most of the time, I'll also tell you some exception to the rule. The most of the time, the length of the murmur is directly proportional to severity of AR. Austin Flint is one more hallmark. This can only occur if mitral valve is normal. If mitral valve is normal, the jet actually hits on mitral valve, AML specifically. You can actually see it in echo. It starts fluttering and slightly closing, so that when the atrial contraction occurs, the pre-systolic part gets, there is a presence of this murmur in pre-systolic area. It's not a pre-systolic accentuation as you see in MS. In MS, you have pre-systolic accentuation, whereas in AR, there is just a pre-systolic component. Let's come to the difference between Austin Flint and MS in a short while. Now let's concentrate on AR. So chronic AR, murmur best in the left third intercostal space. Long murmur means severe AR. Decreased diastolic BP means severe AR. Now, how do you distinguish chronic and acute AR? I think this chart summarizes it very well. In acute AR, remember chronic AR, long murmur and S4. This is chronic AR, okay? Long murmur, S4. Cardiomegaly, a low diastolic BP, and a decrescendo long murmur, all peripheral sign. Austin Flint is present. Acute AR, the murmur could be shorter. Why? Because now the LV pressure and aortic pressure matches. Murmur could be shorter. Usually there is associated S3. This can also have Austin Flint, but Austin Flint in this case is more mid-diastolic and not really pre-systolic. Whereas in chronic AR, it is pre-systolic. Here the Austin Flint is mid-diastolic. But Austin Flint does not help you to distinguish between acute and chronic MR. Now let's see how to distinguish this between PR and AR. Please feel free to type in questions, because if there is anything, I'll be able to answer as we are doing. If you're not understanding or if you want me to repeat something, I'll be happy to do. Now let's see the one more thing about AR before I forget. It's AR because of the valve, AR because of the wall. That's one more difference you should know. When you say valve, it's the valve which is involved. Typically, it could occur in bicuspid or rheumatic heart disease, which is much more common. The valve, a wall, which where the aortic aorta itself is dilated. Typically, it can occur in aneurysms, which can also be. It was earlier syphilitic, but now can occur in Marfan's or any other. In this case, the murmur is best on right second intercostal space, because that's where the dilated aorta is likely to be. It's again, the severity will be almost the same. The key point is S2 or A2, because it's called tambune effect, because it's a normal valve and a dilated chamber above. So once it touches it, then you get a louder second heart sound, okay. So that's what we know as a tambune effect. There are two questions about pre-systolic accentuation. I'll answer it when we come to MS. So in AR, wall versus valve. So wall, dilated wall, it's best in right second intercostal or typical aortic area, and the S2 is loud, okay, because it's a tambune. It's a normal wall which is closing now, will resonate in a dilated aorta. Whereas when it comes to the valve-related AR, it's best in left third intercostal space or herbs area, and then the S2 is typically soft. One usual question which is asked in exam is describe S2 in rheumatic, that's A2 in rheumatic, and describe A2 in bicuspid. A2 in rheumatic is always soft. There is no doubt, because the valve is damaged and it's leaking, it's soft. A2 in bicuspid, there is rule of one third, one third, one third. So in it's one third of the case, it's normal A2, one third it is loud A2, one third it is soft A2. What decides this one third? Actually, dilatation of the aorta. If aorta is dilated, then the A2 tends to be louder. If aorta is narrow and small, then A2 tends to be softer. So the remember rule of one third in bicuspid aortic regurgitation versus rheumatic AR, where it is always softer. Also, the important thing, if you have a single aortic valve problem and clinically no other valve, your first diagnosis actually, along with by calling it severe AR, severe chronic AR, LV dysfunction, and all that, at the end, etiological diagnosis, if it is single aortic, If the person is between 15 to 65, it's likely to be bicuspid. If it is more than 65, it's likely to be sclerodegenerative. That is single aortic. If it is multivalve, then your diagnosis is likely to be rheumatic. So I hope AR, we have answered all the question. AR, the length of the murmur, severity, the site of murmur, valve versus valve, acute AR versus chronic AR. There's one condition where the murmur can be long and musical, but the AR may not be severe. That's when there is a valve perforation, which can occur iatrogenic. When we pass a wire by mistake, you go through aorta. Then the AR is not really severe, but there is a continuous flow occurring from a aortic leaflet to LV. Continuous. And this murmur is loud and musical. So there is a loud musical murmur, but it may not be severe. This is just one exception. Otherwise, in almost all cases, longer the murmur, the severe the AR. Okay. Now let's talk about PR. Typically, we think AR and PR are, like brothers and sisters, and they're very closely related. They are, but in PR, we should understand whether it's a high pressure PR, which occurs in anywhere where there is LV disease or where there is a pulmonary artery hypertension, or low pressure PR. Now, high pressure PR, or what we call as a gram steel murmur, typically is almost like AR. It's very closely related to AR. So they look the same. They, if you auscultation wise, they almost look the same. The difference is P2 is louder in this situation, and the murmur follows P2. There is A2, there is P2. AR follows A2 immediately, whereas hypertensive PR or a gram steel murmur follows P2. So signs of PH helps you to make a diagnosis. So if you have a Eisenmenger or if you have a severe PH, a murmur which looks like AR, but absolutely no peripheral signs, but you have signs of PH, that's where you make the diagnosis of hypertension or high pressure PR. So that's very important. But remember one dictum, which is extremely important. If you're dealing with a rheumatic heart disease, you have MS, you have MR. If you're dealing with rheumatic heart disease, in which case the murmur, even if you get a murmur like PR, hypertensive PR, you are very much, do not make diagnosis of PR. If your diagnosis is rheumatic, it's likely multivalvular. So you should always diagnose it as AR. That's the rule. Please remember this. No candidate has ever passed the exam by making a rheumatic PR. Okay, hypertensive PR as rheumatic, no one. But if you have Eisenmenger, severe PH, you could make a diagnosis of PR. Hand grip and dynamic auscultation, anything which increases the aortic pressure, like squatting and hand grip, typically increases AR but does not increase PR. So remember, PR hypertensive looks like AR, hears like AR, but it starts with P2 and not A2. But in rheumatic, make a diagnosis of AR, do not make a diagnosis of PR. But if you're dealing with PH physiology or Eisenmenger physiology, you make a diagnosis of PR. Typically, most these cases, because PA is dilated, you tend to get a vascular click, not a valvular click, not the expiration click, but a vascular click. A click in PA which increases with inspiration and not with expiration. So that's where we are in a hypertensive PR. Now, this is extremely important. How do you distinguish a normotensive PR and a hypertensive PR? For that, if it was a classroom, I would have asked you how many of you actually have ever heard of a normotensive PR. If you have heard once, you'll never forget, because this is a low pitch murmur. It's not a high pitch murmur at all. When you auscultate, you will not think I am auscultating AR kind of murmur. No, it's totally different. This is very superficial. This is scratchy. This is like a pericardial rub. It's a crescendo decrescendo. It's typically a MDM. Why? Because early, see the one we have in gram steel, the pressure gradient starts immediately. Hence, the murmur starts coming down. Just look at the phonocardiogram where you can see the gram steel murmur. Whereas in when it's a low pressure PR, as you see in absent pulmonary valve or in TOF without where the valve was removed. Any post-op talk, please look for this murmur. It's a very superficial scratchy sound. It's a MDM. Why? In the beginning of diastole, at that end of systole, the LV pressure, RV pressure and PA pressure is almost the same. So there's no gradient. As RV goes into isovolumetric relaxation, RV pressure falls. PA also falls, but not to the same extent. So now there is a gradient between PA and RV. Hence, initially there is no murmur. Then there is slight murmur, and towards end again the pressure equalizes between PA and RV. Hence, it is a MDM. It's but it won't be like MS. Believe me, it won't be like MN. It's not rough rumbling. It's more superficial, more scratchy. It's like pericardial rub. It's a very distinct murmur, and you need to. It's like a wood saw murmur, which is seen in typically in absent pulmonary valve. It's wood saw. That's because, like, that sound what they make when they saw the wood. It's typically a little irritating, very superficial, very scratchy sound. And once you get, you don't get. You'll never forget. What is the difference then between a high pressure? High pressure is typically like AR, so it's a decrescendo starting with PR, pH, and signs of pH is present. Whereas normotensive, it's crescendo, decrescendo. It's MDM, delayed onset. It's medium to low pitch, typically low pitch. Hence, will be best heard with the bell of the stethoscope. So remember this. This is very important murmur. Now, what is the other important thing here? So the other thing is the MDM, because it's a very important thing. Nobody can, pass exam without knowing mitral stenosis and MR. So when do you get MDM? You get MDM in multiple conditions because there are lots of flow murmurs which are MDM, and there are also organic MS and DS murmur which are MDM. So typically MDM occurs whenever there is excess flow through the AV valves. That's where the MDM occurs, or there is obstruction to flow. So MS, TS, classical example. You can also find it in MR. You can also find it in VSD and PDA. You can also have this, probably Austin Flint also is a typical MDM murmur. So that's where we get MDM. So on RV side, you can have tricuspid stenosis or ASD, which is also MDM. On LV side, you have MS, Austin Flint, CARICOM, and the flow murmurs of VSD and PDA, and atrial myxoma or atrial thrombus, which also produce obstruction to flow, can produce MDM. Remember, it's a bigger lift. Now, whenever we say a VSD producing MDM and a MS producing MDM, now I want you all to think about it. All of you have examined MS and all of you examined VSD. Are they same? No, they're definitely not same. When you get a VSD MDM, it's typical. I want you to imagine it and remember this. It's like S3, which is slightly pulled. That's the MDM you're talking about. Whenever you see flow MDM, do not get confused to MS MDM. All of you know MS MDM. It's as if somebody is walking on a forest. It is very rough. It's rumbling. It's pretty long most of the time, which is along with the severity of the murmur. But a VSD, PDA, and sometime MR, you know, in all these conditions, you get a S3. But if you slightly pull that S3, you get, that is the kind of feeling which you get with these MDMs. Again, if you put your stent hard, it's going to disappear. That's how you know it's these MDM. So do not, I'm sure it's, in VSD PDA, it's actually said that it is absence of silence of diastole. Diastole is generally silent, and whenever you have a flow murmur, that's absent of silence. That means you hear something. When you're really not sure what you're hearing, you hear something. That is the MDM which occurs in this classes. Although we describe so many things as almost same, and you tend to get confused when we describe it. Practically, they're not that same. So if you have auscultated enough, you can easily distinguish each of them, even without doing putting too much mind to it. Now let's talk about MS, because that's very important. More severe, it's very important that you understand the graph which has been put here. This is the LV pressure tracing, and what you see in three different color is the LA pressure tracing. As MS is severe, there is more and more pressure in LA, and since there is more and more pressure in LA, the murmur becomes longer, it becomes rougher, and there is also it also becomes you know it becomes like almost like, except for A2OS, it becomes almost holodiastolic. We don't call it holodiastolic, we also call it long diastolic. So what makes us think there is MS? If there is a rough rumbling murmur which is there in diastole, invariably with pre-systolic accentuation, that's what makes us diagnose MS. Okay, and how do we tell severity of MS? Length of murmur. Longer the murmur, more severe the MR. Pre-systolic accentuation is almost there. There was a question, I'm going to answer it now. It's almost always there. It's typically the hallmark of MS. Presence of a pre-systolic accentuation is typically a hallmark of MR. Longer murmur is more severe. Louder murmur also is more severe. What rules out MS? LVS3. If you have LVS3, you are not likely to have a significant MS, or you could have an eco MS, but clinically you will not be, you should not say LVS3 and MS together. You should not say that at all in exam. So if there is S3, LVS3, RVS3 could be there. If there is LVS3, then there is no MS. Now let's talk about pre-systolic accentuation. What produces it? In a sinus rhythm, it's very easy to understand that end of the diastole, as the mid-diastole, there is some blood in LA, and the atria gives it boost, and then the pressure it increases. You hear a louder sound. That's what you get typically in sinus rhythm. Now the question is it there in AF? Obviously the answer is yes, it is there in your AF. You can just check your Hutchison. Your Hutchison itself explains that it is there in AF. So in AF there are short cycles and long cycle. Now long cycles are long, so it's okay, but a short cycle, you should realize that in a short cycle there is already a blood in LA and LA pressure is higher. As the systole starts, remember it's pre-systolic, it's not really diastolic murmur. The pre-systolic accentuation, the mitral valve starts going up. As the mitral valve starts going up, you realize that there is still blood in LA, and that produces excess turbulence, and that itself produces a pre-systolic accentuation. I'm going to just repeat it. See, it is very little controversial. Any controversial topic in exam, don't be too dogmatic or too strong on that. If your examiner wants you to tell the other way, be flexible. Exam is not a fight, and even if it's a fight, the only one who could lose is you. Your examiner can never lose. So be very flexible in things which are not that important. But most of us believe, and most of your books believe, that even in AF, you could have pre-systolic accentuation. And the mechanism is, as the mitral valve goes up, if there is more blood in LA, because MS, there is some blood in LA. When it goes down, there will be, orifice will typically become narrow. There will be pre-systolic accentuation. That will be easily seen in shorter cycle, but some long cycle, it may not be there. So pre-systolic accentuation is almost always there in all MS. S3 is almost always never there. A2OS gap, all of you understand, higher the LA pressure, earlier the mitral valve will open. So A2OS gap is inversely related to severity of MS. That's what you should understand. It is inversely. Why? Higher the LA pressure, quickly it opens. At this point, there is 2, 3 other question which is asked here. I'd like to just touch upon that. What happens to A2AS gap in associated condition? Like what happens if there is MS, it's inversely related. Now the patient has MS, but he also has MR or AS or AR or hypertension or maybe LV dysfunction, different combination with MS, and how would that affect the A2OS gap? Now, there are only two determinants of A2OS gap: LA pressure and fall of LV pressure. No, higher the LA pressure, quicker is the A2OS, or narrower is the A2OS. So, severe MS, narrower. MR, again the LA pressure becomes very high, hence the A2OS gets narrowed. Okay, severe MS, it is narrowed. Independent of that, MR, the A2OS gets narrowed. Remember that. All other conditions like hypertension or AS, what actually happens is fall of LV pressure is slower. Why? Because LV is more thicker. So in AS, AR, hypertension, the LV is more thicker, hence its fall of pressure will be slower. Since the fall of pressure is lower, A2OS, the mitral valve actually opens later. The A2OF widens. Okay, so let me summarize here. Associated lesion in MS, if it is just MS, it's very simple. It's inversely proportionate. Severe the MS, smaller the A2S, lighter the milder the MS, longer the A2S. Among associated, only MR shortens it. All other conditions, AS, AR, hypertension, actually widen it. Why do they widen? Because fall of LV, LV is now going to relax slowly, and if LV relaxes slowly, the valve opening is pushed on the other side. So they all other condition widen A2S except MR. Okay, just please remember this. Even if you remember the last line, probably it is enough, but remember it's something which people will ask you a lot. There are some questions, I'm going to take them later. So the next topic is TS. The murmur is very much similar to the MS, and it rarely occurs without MS. TS is almost always there whenever there is MS. So that means you have to identify now two opening snaps and two diastolic murmur. Tough job, but you can do it. This murmur is more in the left lower sternal border, and here, it's a MDM, just like MS. But one word again, as an offbeat word, this murmur, when you listen to this, it looks, sounds little different. It sounds more like AR murmur. Remember, when you think there is a AR like murmur in the third, fourth intercostal space, but it's not AR, suspect TS. Okay, this helps you. It looks more like AR when you actually auscultate. And please remember that if there is no AR, and if you think there is something like AR you're hearing in the lower part, it could be TS. But typical description is actually like MS, and the way to distinguish it is it increases with inspiration and more on the right uh, sternal border. So I think PR with normal pressure we already discussed at length, and I think all of you did understand. The other word of what we need to distinguish is Austin Flint murmur. This is an important question, and which is typically it will be asked. One important point, remember Austin Flint occurs with normal mitral valve. So whenever you talk about Austin Flint, aortic valve is an issue, but mitral valve is normal. So if you already have MR or some mitral valvular pathology, do not think about Austin Flint at all. Now, as we discussed, it occurs both in MS, both in acute AR and chronic AR. Both of them occur. The mechanism is when the jet falls, it falls on the AML and it starts fluttering. And as it flutters, as there is an atrial boost, you can hear the murmur is heard. How to distinguish from MS? Voice is not clear. I hope it is clear now. Sudhakar, can you hear me?
Sir, it's audible, sir. It's very well
It's
audible.
audible now. Okay.
Yes, sir.
So, so how to distinguish from MS? The most important point is there's no opening snap, there's no loud S1 and things like that. But in murmur, apart from associated lesion, in murmur itself, this is a typically there is no accentuation. Accentuation means increase. In Austin Flint, there is no accentuation, whereas in MS, there is accentuation. There is pre-systolic accentuation, and you have to diagnose it only when you know mitral valve is typically normal. Anything which increases the aortic pressure, like hand grip and squatting, would actually typically increase Austin Flint, but these tend to increase the heart rate, and hence MS murmur also tend to increase. One true way of distinguishing, which in you need to answer it, but probably people will not ask you to do it, is using amyl nitrate inhalation. If you do that, aortic pressure decreases, hence Austin Flint will come down. But amyl nitrate is a venodilator and a vasodilator. So there is tachycardia and the mitral murmur actually increases. So that's the typical difference what you get in this thing. This, I think, carichrome murmur, most of you know, it occurs in acute rheumatic fever because of valvulitis. It mimics more like a flow murmur. We already discussed about flow murmur. This is very important. You're not going to get confused with this and this because these are shorter. Remember, these are pulled S3 and not really murmur. It's just a pulled S3. Okay, so not late diastolic or pre-systolic murmur we discuss. So let me just quickly go through continuous murmur. It's already 6:43 now, and I think we should finish it today, the class, and not postpone it. So continuous murmur and to and fro murmur. This is something which you will be asked in exam. So whenever there is a continuous murmur, it starts in systole anywhere, but preferably near S1, crosses S2, and goes into some extent to diastole. Okay. Now the question is, there are to and fro murmur, typically ASAR or VSD-AR. That means there are two, the one murmur which is long like VSD, plus there is AR. There's a to and fro murmur. So typically question which is asked is, how do you distinguish between these two? This is what. So you should be ready to give this answer. The answer to that question is that in a continuous murmur, it is same murmur. That means it is originating from one zone, like maybe aorta and PA, or in RSOV into the one of the chamber, typically starting from one chamber and going to one more chamber. Chamber doesn't change. So the pitch of the murmur remains the same. The pitch of the murmur. Remember that. The pitch which we discussed, your friend's motorcycle, that remains the same here. Intensity, on the other hand, changes. That means if you are careful enough when you keep a stat, it is the same murmur which is going here and there, but I am finding it louder here or louder there. Whereas imagine a VSD and a AR, or AES and AR. When it's VSD, it's a different murmur. You can actually make out a lot of eddy current, and AR, which is a pure high pitch murmur. So the pitch changes there. The key word is pitch. I know it's a difficult word, but that's a keyword. The keyword in a continuous murmur, pitch remains the same, whereas in a to and fro murmur, pitch varies. Now, intensity, on the other hand, keeps varying. For example, PDA peaks at S2, only PDA. Among all the continuous murmur, only PDA peaks at S2. So if you are decreasing continuous murmur with eddy current and all that, then it is PDA which peaks at S2. Whereas RSOV, which is a ruptured sinus of Valsalva, depending on the chamber and depending on the PA pressure, could peak before S2 or sometime peak after S2, but typically does not peak at S2. So that's something which you should understand. There are at least 10 causes of continuous murmur, and you should know all of them by heart. And when people ask, you should be able to list it. That's one more funny part of the exam, because examiner has a short time to assess you. It's going to be a lot of rapid fire. So remember, when they ask continuous murmur, if you know 10, just tell 10. But how do you distinguish to and fro? Is the pitch of the murmur. Okay. Now, when you are looking at, say, I'll typically concentrate on PDA and maybe RSOV, and not about mammary shuffle and such murmurs which are easy for you to understand. So when you're talking about PDA, there's something special happening there. There's a PA jet, there's an aortic jet, there's one more jet which comes from aorta and hits the PDA. So remember this, that there is lots of eddy current. So machinery murmur in PDA occurs only if the PA also has a proper jet. Okay, when the PA also has a proper jet, there is a machinery murmur. It comes and it jets. So even only at that time there is a proper machinery. There are lots of conditions where PDA has continuous murmur, but not machinery. Because for machinery you need extreme eddy current. So, for example, if there is a TOF and PDA, there is hardly any flow in PA or pulmonary atresia. In such a case, you get a continuous murmur in PDA, but it is not eddy or it's not machinery. So, machinery murmur is a feature of PDA where the PA also has a good flow and there is lots of content. And typically, PDA without much pH peaks at S2. Okay, all other murmurs have peak here and there. So please remember how to distribute to and fro and this. So here the chart here gives you a lot of list of including a Luttenbacher and but the favorite is actually PDA and RSOV. Others are all fistulas can also produce a continuous murmur. So I was talking about PDA. One very important about PDA is, imagine you examine left second intercostal plate, which is a typical PA, and you get a systolic murmur there. And if you are not kept in this infraclavicular area, you could miss a PDA. Please remember that whenever you get a pansystolic murmur anywhere in the precordial area, put your stat below the infraclavicular area. When you do that, you might unearth a PDA murmur. It may not be as loud as you want it to be. There's lots of eddy current, but the loudness is variable. So it's also possible that you're only hearing the systolic part lower down and the continuous part is infraclavicular. So do not miss this point. 2-3 points you should not miss. One, carotid examination and auscultation, right-sided lower part, because RSOV murmurs can be right side, some TR could be right parasternum for auscultation, and left infraclavicular auscultation for PDA. So these are some extra auscultation you should always do. Okay, remember this. Now I think we did discuss these things, and let's in 2 minutes I think I will, let me concentrate on dynamic oscillation, and with that we could stop. So I hope most of you did follow the the systolic murmur, the diastolic murmur, and continuous murmur. There's obviously there's so much more we could discuss, but I want you to have a framework on which you could work, and maybe you can ask Sudhakar or me the doubts which you have. Now, dynamic auscultation, which we need to see is, why do we need to do it? We need to do it in all cases. Remember this, all cases, whether it is MR, whether it is MS, whether it do some sort of dynamic auscultation. Unless you mention it, it's going to be wrong. The typically maneuvers of dynamic auscultation could be respiratory maneuvers, which are very easy, and most of us, best in inspiration, best in expiration, we always say. But making the patient stand and sit also helps you. So the maneuvers could be positioned like in lateral, lift, physical like Valsalva, which is very important. After all, Valsalva is the most important. I hope we have time to discuss that. Pharmacological, you need to know theory of it, but you don't need to do it. We already know about lateral position. All left-sided murmur will be best. Leaning forward is very typical for AR and PR. Leg dangling is important. Leg elevation or inspiration are typically best done for right-sided murmur. Now, what does standing do? And most of the time, when you stand, except two murmurs, almost all other murmur when you stand, because of decrease in cardiac output, murmur intensity is actually decreases. The murmur increases, intensity actually decreases. Other than HOCM and MVP, in both these, it behaves ulta. That means they are typically opposite of other murmurs. And when we discuss Valsalva, I'll discuss about what is the difference between these two. I'll pass on the inspiration expiration is a very important maneuver. Most right-sided event like RVS3, RVMDM, TR murmur, TS murmur, and pulmonary vascular ejection. These sounds actually increase with inspiration, and you'll be surprised how well it works. Please do this, especially for S2 split and all this. Please do this same way. You could also do them to do Muller maneuver, which is inspiring with closed glottis, or leg raising. Believe in these maneuvers. Like I discussed, you need to become a believer. If you believe in this maneuver, they will work well for you. Whereas in expiration, you realize that the moving left side expiration, the left side murmurs are typically better, like MR is becomes better, AR becomes better, but generally the effect on right sided is much more than effect on left sided. So that's what you should understand. Now let me just talk about Valsalva and make it easy, because Valsalva is little complicated if you don't understand it. And this is a maneuver which you should learn to do it perfectly well, because Whenever you have MVP or HOCM, your Viva is actually on Valsalva and not on this. So please understand Valsalva. When we talk about Valsalva, I know the graph looks complicated, but let's do how to do Valsalva. One is that you can't ask the patient to strain. That's just not possible. So if you have a BP cuff, the mercury one, remove this and ask him to blow and maintain the pressure at around 30 to 40, between 30 to 40. Or you could keep your hand on the patient's stomach, ask him to stop breathing and press your hand up. So remember, either by blowing the BP cuff between 30 to 40 or press your hand on the stomach and make him, ask them to hold. So this is how you do Valsalva. Now Valsalva has 4 stages. You need to divide those stages and understand very well. Okay. So out of that, there is phase 1 and phase 3. They are passive phases. Phase 2 and phase 4 are reflux phases or active phases. Valsalva, 4 phases. We know how to do: blow or ask them to push your hand up. Now, what are the passive phase? Stage 1 is a passive phase. So what happens? You ask, now there is a strain which is given, which could be through this or this. So there is a raised intra-abdominal pressure. Now this gets transmitted to aorta. So what happens to BP? In stage 1, the BP increases. Imagine, let me take BP as 120/80 to start with. When person gives this pressure, the systolic becomes 130 and diastolic also goes up. So from 120, because he has given pressure, the BP has gone up. So let's take this example. It was 130 and the BP has gone up to 155. So there was a 15 millimeter increase in the systolic BP which occurred just because, or 25 millimeter in this case, just because patient has exerted that much pressure. What happens to heart rate? Nothing. Why? Because it's a passive phase. Passive means just passive transmission of the pressure. 1 and 3 passive. So all they do is either the pressure is transmitted or pressure is released. There is no change in heart rate in 1 and 3. Okay, 1 and 3 passive. So here the pressure, the systolic BP actually goes up from 130 to 155. Why? Because there was a pressure transmission. What happens now? Although the BP has gone up, the venous return is completely shut down, and because of that, the BP falls. So in stage 2, which is a reflux stage or active stage, the BP falls. Because BP falls, heart rate rises. Remember, heart rate follows BP in Valsalva, not the other way. It's not change in heart rate, which is heart rate follows. So the BP, because the BP has fallen, the heart rate rises. So understood? Stage 1, passive increase in systolic blood pressure, no change in heart rate. Stage 2, reduction in the BP, which led to tachycardia. Now what happens in stage 3? In stage 3, the pressure, now BP is already now say down to 100 from 130. So from 155, it's a massive dip in BP. When you release it, the stage 3 is again a passive stage. You ask the patient to release it. He's released it. The BP actually falls further. Why? By the degree of the increase in the stage 1, which was 25 in this example, it gets fall further of 25. So if it was 100 here, it's going to go down to 75. You understood? Stage 3. Stage 1, balloon is pressed. Stage 3, balloon is released. So whatever pressure in stage 1, it goes up. In stage 3, it actually comes down. Although you released Valsalva, the pressure falls further. To the same degree, it rose in stage 1. Heart rate, no change. Why? It's a passive stage. And what happens in stage 4? There's so much blood rushing in. So there is a passive increase in BP, which will be much more than any. So there is a rebound hypertension. Because there is hypertension, the blood pressure, heart rate falls. Heart rate follows BP. Okay. So just to summarize once again, stage 1, 0 is normal. Stage 1, passive. No change in heart rate, BP goes up. Stage 2, BP falls, hence heart rate goes up. Stage 3, although there is a release, because there was a passive element, BP falls further. Stage 4, there is a rebound high BP, and hence the heart rate decreases. Now, in the strain phase, when we say Valsalva, in the strain phase, that is state 2, all murmurs decrease except MVP, which increases in duration. Why LV is empty? MVP increases in duration, and SCM becomes louder because the gradient. MVP does not become louder because LV to LA pressure remains the same. But because LV is empty, it's going to prolapse earlier, and the length of the murmur increases in MVP, and the intensity increases in HCM. Whereas when you release, finally, the right-sided murmur increases by 2 to 3 beats, whereas left-sided murmur increase by 8 to 10 beats. That's how you distinguish right and left. All of them decrease, but when it is right-sided, the in stage 4, the increase occurs between 2 to 3 beats, and in left-sided murmur, it occurs 8 to 10. There's one murmur which is not affected by Valsalva, that is VSD, because it's an intracardiac murmur. It is not affected because here it's after all effect between right and left which plays a big role. So intracardiac murmur of VSD is unaltered, and ASD removes the ASD. You get what is known as a square pattern, not square root, square pattern, because there is no reflex phase. So BP either goes up in stage 1, comes down in stage 3. No 2, no 4 in ASD. No 2, no 4. No 2 and 4 are reflex. So they do not happen in ASD. So it goes up and comes down. That's called square pattern. In TCP and in condition like heart failure, stage 4 is not possible because the body does not have the capacity to increase the BP beyond a point. So stage 4 is not possible in CCP and CHF. So just to summarize, all murmur decrease in stage 2 except MVP, which becomes longer, and SCM, which becomes louder. Okay. At time of release, which is stage 4, right-sided murmur pick up quickly in 2 to 3 beats, whereas left-sided murmur pick after 8 to 10 beats. Okay, please remember this. And 1 and 3 passive, 2 and 4 active. BP fall first, heart rate next. That's all you need about Valsalva. Okay. Now, this is what we discussed. I think all of you know this. This is what we are talking about in ASD. In ASD, you just have what is known as a square response, not square root, square response, where it goes up and down without actually changing. Okay. This is a good slide which tells you that a failing heart cannot have stage 4 flat response and all that. I think isovolumetric expands like hand grip increase SVR, hence increases murmur, which are responsible by SCR like AR, even MR-VSD, because the LV pressure actually increases. MDM of MS is increased because of tachycardia in isovolumetric exercise. MVP and HOCM behave opposite. This is opposite of Valsalva isovolumetric. As SVR increases, LV becomes bigger. A bigger LV, less MVP, less SCM. That's all. Just think LV, whichever condition, LV is going to be bigger, like more fluid, more venous return, there MVP and SCM becomes less. Isotonic exercise also important, especially to pick up some cyanosis which you have missed, or MS. All MS patient, you are not sure about this, make them walk a little bit and you will get. So amyl nitrate and all that, I think it's just theory. So please read about that. And I hope this was useful. And maybe I'll try to take questions as much as possible. So first few are okay. So recording, this is most of them are for Sudhakar, I think, to send the recording. Difference between pre-systolic accentuation and a pre-systolic component by Dr. Damodar. So pre-systolic accentuation means murmur increases, it becomes louder. In pre-systolic component, the murmur remains the same, but we can hear it. Pre-systolic accentuation AF is definitely present, but little controversial. Relation of dynamics, murmur relation. Yes, in acute AR, murmur could be shorter because the LV EDP is higher. The gradient is lesser. The BP, there is no cardiomegaly. They have more S3 than S4. Shorter murmur, sicker patient is acute AR. Can you elaborate valvular and vascular click? Valvular click occurs because of the valve. So it typically occurs because of aortic and tricuspid mitral valve, aortic and pulmonary. Pulmonary valvular kick is best in expiration. Aortic alveolar kick generally doesn't change, whereas a vascular click is because of dilated aorta and dilated PA. So they follow the usual route. Since the pulmonary will increase with dilatation. Where to distinguish? Look at carotid. If it occurs when you feel carotid, if you are getting with the carotid, it's likely to be vascular click, because it is the dilated vessel. If it occurs slightly before, still systolic, slightly before, that would be valvular. Okay. Now, the S3 and S4, yes, both are low pitch. So you keep the step, you hear the sound. If you press it, it will disappear. Now, the key point is S4 appears like split S1. It's very close to S1. So like a split S1. I wouldn't want you to remember before and after. Remember split S1, whereas S3 is like split S2. It makes sense for us to, understand the sounds closer to S1, S2 rather than confusing it more. So S3 split S2, S4 split S1. Acute MR and acute AR. Both are sick patient, but in acute MR, LA pressure is very high. You get a strong S4, no cardiomegaly, huge pulmonary edema. Acute AR, you get S3 because there is rapid, there is pre-closure of the mitral valve, lots of pulmonary edema, shorter murmur. Okay, and please make arrangement for lecture. This for Sudhakar. Sir, MS mitral valve is abnormal. Why is it necessary? Yeah. So if you are sure about MS, Dr. Kiran, if you are sure there is a romantic MS, see the question which examiner is trying to ask is when you find a MDM, they are asking you. We know you have picked up AR. We are there's cardiomegaly. There's all the finding of AR. So what they are asking you is there MS or is it Austin Flint? There can only one of the one possible. If you think it is AR only, then the diagnosis is bicuspid and it is different. Whereas if you pick up a MS, it's rheumatic. That's what they are trying to ask you. Okay. Flow murmur of MR again is it's a MDM, but not like MS MDM. It's like a little pulled S3. That's what you should remember. Okay, propagation and radiation. Yeah, we did it last. Selective propagation is radiation. Okay, second best. So mitral murmur radiates to apex. The aortic murmur radiates to carotid. Everywhere else it is conduction. A loud murmur is heard all over. So if you have equidistance on all of them, then it is conduction. Conduction is like heat. One point, equal distance, all points are same. Radiation is selective propagation, the second best. Hand grip on MVPMR, yes, hand grip is an isometric exercise. When you do that, LV now becomes bigger. If LV is bigger, MVP is less. That means the click goes more away from S1 and murmur becomes less. A component and accentuation is not same. Component is just the same murmur. Accentuation, the murmur becomes louder. Continuous from to and fro. Once again, yeah. So continuous murmur is same murmur, but intensity change. When you keep a step, it is one murmur. There is a signature of a single murmur. So that signature is the pitch. Pitch remains the same. It could become louder later. Whereas a to and fro murmur like VSD AR or ASAR, they are two different things, but they are together because the heart is because of cardiac cycle, but their pitch and the signature actually becomes different. Yeah, RSOV and PDA are very close mimic. Specifically to PDA, murmur is best in the intraclavicular area, peaks at S2, LVS3, MDM is better. RSOV is much lower down, much harsher murmur, but lower down, and it has a typical this. Can you please repeat what happens in stage 4 of This must be Valsalva. Stage 4 is a release stage because now there is gush of blood which is coming out. And if LV is normal, there is going to be hypertension. There's going to be increased BP, which occurs, which is a hypertension. And because of hypertension, there is bradycardia. Right-sided murmurs pick up when you release. If it is a right-sided murmur like TR, PS, by 2 to 3 beats, their intensity increases because immediately blood gushes. It has to go through the right heart, then go to left heart. So right-sided murmur increase in intensity quickly versus left-sided murmur. Others are only for this one. Yeah. Difference between click, constant, inconstant, vascular. Yeah, click are classified into ejection, non-ejection, phasic, non-phasic, and vascular, valvular. So ejection, non-ejection is whether it is related to ejection. For example, both pulmonary, vascular, valvular are related to ejection. They're ejection clicks technically. Phasic means relation to breathing, which increases with inspiration, what increases with expiration. Non-ejection is like MVP. It's not related to ejection, but typically related to LV volume. Best bookwork cardiac auscultation you prefer? I'm not sure. If I find, I'll definitely text you that. General question, your comment on telling diastolic pressure of lower limb during the case of present. Yes, the diastolic of lower limb is important for one reason only. It is the systolic which decides, but diastolic decides the cuff size. It doesn't change. For example, if the upper limb BP is 120/70, lower limb is 180/90. Okay, so the amount of error in diastole tells you the error because of the cuff size. Okay, if the cuff size, if you had a thigh cuff size, then the BP would have been 160/70 because 70 should have been 70. It doesn't change. But if 70 has become 90, that means that much error is because of the cuff size. You need to minus that error from systolic. So 180, the error was 20, you minus it to 160, and that's where the diastolic BP helps. Otherwise, it doesn't help at all. No, MVP murmur does not become louder because LA and LV pressure gradient does not change. It only becomes longer, doesn't become louder with Valsalva. Mixed frequency murmur. Can we use the mixing? That's a controversial topic. I would recommend that most of you should use stick to high pitch, low pitch, but back of your mind, understand that AS and VSD are actually mixed pitch. There are set of examiners who really like it, and that's different. Pitch and intensity are two different things. Pitch is the basic quality of murmur pitch. For example, low pitch of MR, MS is low pitch rumbling, it's much harsher, whereas MR, high pitch is much, much milder, it's not harsher. Whereas loudness, length, typically length is only determined by the pressure gradient and it varies. Okay. Yes. What happens to VSD with phases of respiration? Nothing. VSD is intracardiac, so nothing. It doesn't change with phases of respiration or with Valsalva. Okay. So Sudhakar, I think if you have done.
I think I think all questions are covered, sir. I think such a big topic you have covered in 2 classes. I think it's very well, sir. I think everybody understood what the things are. Actually, each of these is a separate class. I think there's such a lengthy topic. Each even dynamic auscultation, but you have covered it very well, sir. So I think we'll conclude it, sir. Actually,
Yes, we'll conclude
yes,
it. No, yeah.
yeah,
And, I think Sudhakar, I'll send the slides to you. You
yes,
can
sir.
share with people if
Sure,
you
sir.
want. Okay?
Sure, sir.
If they are
Sure,
doubt, they can write it back. Okay.
sure, sir. Yes, sir. Mahendra.
Yeah, thank you, Dr. Ranjan sir, for a wonderful presentation. And now I request Mr. Abhilash, our regional manager, to do vote of thanks.
Yeah, good evening, everyone. So I'm Abhilash here from Abbott Vascular. Hope everyone is doing fine.